Hey guys, welcome to my channel where we discuss anything and everything to do with psychology and mental health. In this video, I'll be doing a Q&A based on my last video. Before we start, I just want to say thank you for the response on my last video, thank you for watching, and thank you for being so supportive. So my first question is, what is a cognitive behavioural therapist or cognitive behavioural psychotherapist? Well, a cognitive behavioural therapist and a cognitive behavioural psychotherapist is essentially the same thing. They're just two terms that are used interchangeably and used depending on how the therapist wants to define themselves. Essentially, they're both therapists that practice CBT. And CBT is a form of psychotherapy that focuses on identifying, examining, and modifying thoughts and behaviours. Cognitive behavioural therapy focuses on cognitions, so what people think, and behaviours, so what people do. And the general belief in cognitive behavioural therapy is that thoughts, feelings, behaviours, and physical sensations are all interlinked. So if you change one, it leads to changes in all the others. So as a cognitive behavioural therapist, what you do is work with the individual and try and identify and monitor their thoughts and behaviours and feelings and physical sensations to get an idea of the pattern of what the individual is experiencing. And once you have identified the pattern, you formulate together. And what a formulation means is that you identify the things that are maintaining the individual's presenting problem. So a presenting problem is depression, anxiety, PTSD, anything that's impacting the individual. There's a general misconception that we don't focus on early experiences. We do, in the context that we know that early experiences influence beliefs and schemas that individuals have about themselves. And in CBT, that's called core beliefs. CBT therapists focus on the present. So they focus on why you're feeling the way you're feeling right now and what can you do now to change it. It doesn't focus so much on the past unless it's relevant to what you're experiencing. So for example, if a core belief is a maintaining factor and is going to cause relapses, let's say, or you have PTSD and going through a past experience is important to your recovery, then they do focus on past experiences, if that makes sense. Please let me know in the comments if that doesn't make sense. I need to add anything to follow up. Well, a day as a cognitive behavioural therapist, every day is different and is dependent on the service you work in. And if you'd like me to do a day in the life, I'll be open to that.
So I can do like a week, or like a week in the life, because every day is different. I can do it as a week in the life, if that makes sense.
But just to briefly answer your question, every day is different and it depends on the service you work in, the time of year, the service demands. It is dependent on a whole load of other things. And even each month or each week is different. So the next question, do you work with other disciplines such as nurses, social workers, as I'm keen on being involved in social work as a clinical psychologist, but I'm unsure what clinical work looks like in the UK. So I'm not a clinical psychologist, I'm a cognitive behavioural therapist or cognitive behavioural psychotherapist, and yes, but I can answer briefly from what I know about clinical psychology. Yes, as a clinical psychologist, you would work with social workers, with nurses, but the degree of involvement with them would depend on the service you work in. So I've worked in acute inpatient settings, in IAP services, in community mental health, and it really depends on the type of service you work in, because you will have more involvement if, let's say, you work in inpatient settings, you'll directly always be in contact with nurses, or with me, I work in a tier 3 CAM service, so you always have contact with nurses, but the involvement just depends on where you work, but you always have some kind of involvement, if that makes sense. And also I'm aware that my eye contact in this video will be all over the place, because I'm trying to like focus on how many questions I have and the time, and yeah, so I do apologise for that. But I am trying my hardest to focus on the camera. So next question. So did you do your course after your master's? So my course was my only master's, and I get this question quite a lot, but I've got a psychology undergraduate degree and I've got a master's in cognitive behavioural therapy, and that's my only 2 degrees, if that makes sense. So I have no other masters. Did you feel the course was sufficient enough for when you started working? I feel like it was sufficient, and that's the key word. It was sufficient enough, but I think one thing that you learn while you're on the course and after you qualify is that you have to continue to keep learning and continue to keep developing, and that's one of the things. So when you're accredited as a CBT therapist, is one of the things that is part of your reaccreditation process. So you have to apply for reaccreditation each year. One of the key parts of reaccreditation is continuing professional development, and that's something you're going to want to do because you want to be the best possible therapist. So you are naturally going to look for opportunities to develop and be committed to current research, if that makes sense. But it's sufficient enough to get you started and get you comfortable. And once you graduate from your postgraduate in CBT, is that you've already done it for 2 years, because you have to start your placement right at the beginning. Over the 2 years, you've actually been gaining that experience, so you get that level of confidence to be able to start working. But then again, each service you work in is going to have new presentations or disorders you haven't worked with, or different combination of disorders that you haven't worked with, and then you're going to continue to learn with those populations, if that makes sense. So the course gives you foundational knowledge of anxiety, depression, PTSD, mood disorders, things like that, but then you have to be able to adapt it accordingly, and that's something that you develop later on in your practice, is that there's no set treatment. It's the person comes in and you have to use the skills and tools that you've developed. And I think the concept that I like is that your journey as a cognitive behavioural therapist is a journey. It's not a destination. So it's not that you complete the course and that's it, you're a final product. It's that you're continuing to learn and develop. But then also with that, it's that you're but then you're going to constantly learn and develop, and you're going to soon realise that everyone's an individual. So yes, someone might have depression and you've got another person with depression, but it's that unique combination of the individual factors that are going to determine whether the therapy is successful or not, if that makes sense. So yes, it's sufficient, but you have to continue to learn and adapt and be flexible. And there are protocols, for example, but you don't use them as rigidly, if that makes sense. Because a therapist should be able to adapt the therapy to the individual that is in front of you, not make them fit a mould, if that makes sense. So you're not trying to fit the client into a mould of what you've already learned. Is that you use what you've learned and you apply it to the individual in front of you. And you learn how to, because it's not going to be someone just comes in with depression. It's going to be someone's got depression, they've got past trauma, or they've got anxiety and they've got autism, or so do you get what I mean? So it's like a combination of different factors, and you have to consider the whole individual, not the issue in isolation, if that makes sense. Again, if that did not make sense, leave down in the comments and I shall try and make sense. So next question, have you done the Low Intensity CBT course? No, is a simple answer. I was an activities coordinator and then I became a CBT therapist. Are you thinking of doing clinical psychology long term? Currently I don't know. I get this question a lot too. I wouldn't say never. I would just say at the moment no, because so currently where I am, I'm the same band a clinical psychologist would be. So I don't know if I would do clinical psychology. I know I'm going to do a doctorate in something. I just don't know what I'm going to do one in yet. So yeah, I would never say never, but not right now, if that makes sense. So how do you find working with patients with psychosis? I think when you work with patients with psychosis, you need to be very open, and you need to realise that each person with psychosis is different, and nothing is really, although they have hallucinations and delusions, no one's going to be the same, and everyone with psychosis is different. I think it's emotionally challenging. I definitely found it emotionally challenging because I worked with inpatient acute psychosis, so people were very unwell, and it's not nice seeing people probably at their lowest point, but that's with anything in mental health, it is difficult. I also found it quite rewarding in that when people are at their lowest, you're helping them and supporting them. And I think that's when they need people the most. So everyone with psychosis is different. They have similar characteristics like hallucinations and delusions, and that's something that you learn in your undergraduate course anyway. But is that when you actually get outside of the textbook and get into the experience, is that everyone's different. No one's like the textbooks suggest. Because psychosis is really hard, there's a lot of stigma around psychosis. There's a lot of misconceptions, I think, and you almost need to reflect on that. And that's what I learned, is that, yeah, I've been around psychosis for a long time. That does not make me any kind of expert, because everyone's an expert in their own experiences, if that makes sense. So everyone knows what they're going through. I have to be inquisitive and curious and learn their experiences and what they're going through. And it's the fact that, okay, yes, they're hallucinations and delusions, but you should not take away from the fact that those experiences are real for that person. And I think once I learned that, okay, these experiences are real for this person, and almost try and step into their shoes, that's when you realise to actually really empathise. I think sometimes the stigma is that, oh, these people are risky. And yes, there is risk there. And you need to familiarise yourself and go to handovers and things like that and familiarise yourself with the risk. But you also need to realise that the risk is there because this person's distressed, if that makes sense. Because no one's going to hit someone else, or no one's going to be violent towards someone else or aggressive. You have to realise this person's doing it because they're in a real state of threat. And although you don't think the topic of their hallucination or delusion is real, to them it is real. I'm going to say it again, does that make sense? So, yeah, I think once you learn, the textbook is good for background knowledge, but treat them as humans first. And although I knew that, it was just like, oh yeah, I've got experience with psychosis. It's just that, yeah, I have experience, but that's limited to the South Asian Pakistani population that I know. So I'm South Asian, Pakistani, Muslim. So your topics are normally influenced by life experiences or something that you've seen, or so like, for example, the people that I know with psychosis, so the people that I know personally with psychosis are Pakistani and are Muslim, so they have specific delusions or hallucinations that someone else might not have, if that makes sense. But yeah, just treat everyone as an individual, and it's emotionally challenging, use your supervision, and yeah, just be open to everyone's experiences. And once you realise their hallucinations and delusions are real to them, then it will help you empathise and understand their behaviour a bit more. Yeah, hopefully that makes sense. Yeah, so those are some of the questions that I got about my past experiences, and hopefully you found that useful. And if you have any other questions, please leave them down in the comments. And yeah, see you in the next video.